Welcome to the No Plateau Podcast for stroke and brain injury survivors, their caregivers, and the therapists helping them to break boundaries in their recovery journey. Hosted by Henry Hoffman, occupational and clinical therapist, this podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. And now, here's Henry Hoffman.
Hello, everyone. Welcome to another episode of the No Plateau Podcast. I am your host, Henry Hoffman. I'm excited to be with you today. Today, we're going to discuss spasticity, why it's often misunderstood, why it's and why getting it right matters so much for patients, caregivers, and clinicians. This conversation goes beyond definitions and treatments and looks at outcomes, access, and what truly drives quality of life. I'm honored to be joined by Dr. Monica Verduzco-Gutierrez, a nationally recognized leader in spasticity management and neurorehabilitation and medical education. She's a professor and distinguished chair of the rehabilitation medicine at UT Health San Antonio, medical director of neurorehabilitation at Warm Springs Rehab Hospital, and the lead author on the AAPM&R consensus guidance on spasticity assessment and management, which we'll definitely touch upon today. So whether you're a therapist, physician, caregiver, or someone living with spasticity, my goal is that you walk away from this conversation with greater clarity and a clear path forward. So Monica, thank you for joining me today.
Yeah, thanks for having me. Very excited to be on your podcast.
Yeah, so before we dive in, I'd hope that you can start off by expanding a little bit more about your personal and professional background. That's okay?
Yes. So I'm a physiatrist. I'm a physical medicine and rehabilitation physician, and I specialize in neurorehabilitation. Also have a board certification in brain injury medicine. For the most part, I'm seeing patients who come with neurologic issues and who have rehabilitation needs around that. Also have made a lot of my practice just happens to be the nature of seeing these neurologic patients is patients who are, recovering from stroke and brain injuries and have spasticity. So that's a part of my clinical practice, as well as actually developed a lot of long COVID related care for patients as they happen to look a lot like neurologic rehab patients too. And that's my clinic work. And of course, I run a department in a medical school and do administrative work and lead research trials and lead research. So full days.
Yeah, fully packed,
Fully
which
packed.
is great.
Yes.
Well, thank you for sharing that. You know, our audience is made up of patients, therapists, primarily, and caregivers. So we'll keep some of the language as simple as possible, but even for the clinicians, I'm sure they're going to want to get into the weeds just a little. So if you don't mind, I want to start off with just some foundational stuff. And this one is a fun one for therapists for sure. It's understanding the definition of spasticity. So one thing that comes up a lot in these clinical conversations is whether our definition of spasticity has actually changed over time. You know, we still hear the classic one from Lance in 1980. Let me actually read. I got this here. Lance's definition: spasticity is a motor disorder characterized by a velocity-dependent increase in tonic stretch reflexes with exaggerated tendon jerks resulting from hyperexcitability of the stretch reflex as one component of the upper motor neuron syndrome. So my question is, has the official definition of spasticity changed over the years? And if not, does it need to?
Yeah, so definitely that is the old school first definition that we all go to and that we all teach our residents, and I put on all my slides. And then my slide says, but that is just one part of, what is the upper motor neuron syndrome and what is spastic movement disorders. So I think that when we think about the Lance definition, fancy way of saying it is it really focuses on the velocity dependent, but not all spasticity is velocity dependent. And so we use this word as an umbrella term. There have been other authors that have come out and, updated definitions over the years, probably, Jean-Michel Gracie's, Pandian, Sheng Li, they all have definitions. And then we have a paper that's coming out soon that's going to talk about the spasticity syndrome and feel like, look at all the definitions and how do you put it together and really describe a disabling spasticity syndrome. So more to come on that.
Okay. Well, yeah. So it's definitely, to your point, it's not just velocity dependent. I know we've had conversations with therapists, or I try to explain to patients about, and I want to get your opinion on how you explain to patients in a second. But from a therapist standpoint, the classic pattern of stroke, you typically have the flexors more involved when you have that spasticity nature appearance. And some will say, well, why is it more flexor involvement from that regard. And what I've been told, and I'd like to get your opinion, is on these, when you look at the inhibitory descending pathways, was more reticular spinal. And when you're at the brainstem primitive level, those were primary dominant by flexor groups. Is that the case, or why is the flexors more involved when it comes to spasticity versus the extensors, from your opinion?
Yeah, I think that is the case. It's like, what are the tracts that are affected more? And if reticulospinal tracts are affected, then that puts going into what is the stronger muscle group traditionally, and that ends up being flexor when you think about the postures that people end up having. So yes,
Okay.
for sure. That's
So
kind of the prevailing thought.
Yeah. And regarding the velocity dependent, because to your point, it's not just velocity dependent. You can be in a resting posture and have active muscles,
Right.
which would be spasticity. This is where it gets a little tricky, because some people patients will describe it as tight, stiff, tone. The language it gets really minimized on what spasticity actually is. So how do you explain spasticity to a patient and family member in everyday language?
Right. So how do I explain it to a patient? So a couple of different ways that I say it. But one of the things when I do explain, if something happened to your brain, I say we have two tracks. You have your part of your brain that tells your muscles to move, but we actually have this other track that comes back the other direction and says, but don't move that much. And that's how we get the perfect movement that we want to move, because we have that bi-directional go and the break. And so actually, when people have strokes or brain injuries, spinal cord injuries as well, the track that usually gets damaged also the most is the break. And so then your brain is just sending the message to go, and then you don't have the stop. And so then that's the muscles that are firing and active all the time. And I think I also have a little picture that I draw. Just, people learn different ways. Some people are visual, some people are auditory. So I have my little picture that I draw too, which I will spare you the not good art right now. But, and then patients understand a little bit with, here's a train that has no brakes now. And so the muscles are just going and firing all the time. And then when we sometimes do procedures and we put, a needle with EMG guidance, they can hear their muscles be active. And if someone was just resting with their arm like that, and I would put an EMG needle in, it would be quiet, but yours is loud because your muscles are always firing. They're firing a lot of the times, or when you move, and so that's part of what spasticity is.
Yeah, that's really good. And, top 4 or 5 diagnoses, who typically gets spasticity that you see the most?
Stroke, for sure. There's a high percentage of patients post-stroke who develop spasticity, especially if it is a more severe stroke or if it is a bleed. It depends on also where it is. I would say that the next one is probably cerebral palsy. A large percentage of cerebral palsy patients get spasticity. Spinal cord injury patients, MS, persons who have MS, traumatic brain injury as well, anoxic brain injury. Those are some of the diagnoses.
Okay. And, another conversation that comes up clinically is, what is the best way to assess spasticity? And I know there's some debate over the modified Ashworth versus the Tardo scale. And can you tell me what's in your toolbox of assessments and what's your go-to?
My toolbox of assessments it's difference per patient, because I do want to see, what is significant for the patient. So a lot of times, yes, I will put modified Ashworth scales in my note, because part of the, if I'm going to do a procedure, the insurance company might want to see something like that. But for me, I also love to see functional. Like, okay, what happens when they transfer? Are they going into a posture? What happens when they try to walk? Because again, there's that action-induced spasticity or action-induced dystonia. And so sometimes they may look fine at rest, but once they start doing an activity, that's when their arm comes up, their foot comes in, their toes curl. So I love if I can safely do a functional assessment that way in clinic. I love getting patients like stood, transferred, walking. That's where I still sometimes even use telemedicine, because I may be able to see them while they're in therapy or while they're at home type of thing, and get to see what they look like in real life. And then I will sometimes do Tardo, especially if I want to look at some spasticity angles and, question on, contracture or not type of picture. But And then there is, marks in the office of what's 10 meters, and I'm going to get them to walk 10 meters and time that. So again, it's kind of different for every patient, and we just kind of do it based on how they present.
So it's a mix, it's a healthy mix of your standard tests as well as functional, it sounds
Right.
like. And do you, with the education side, when you're teaching, do you put a little bit more weight on Tardieu over Ashworth? I mean, the problem that we've always read was with the Ashworth is you can't tell the difference between, neuro versus mechanical.
Mhm.
Where Tardieu is a little bit more because you have that first resistance versus your, R2, your second resistance, and one's velocity dependent, which the other one is just end range. Do you put a little bit more weight clinically on one versus the other? I know probably insurance wise, it's more well known for the Ashworth. But what are you teaching, and what are most students learning when it comes to prioritizing, let's say, these standardized tests or objective
Yeah,
tests?
I would say you're right. The studies on the modified Ashworth, when you look at them, it's like, oh, it can be subjective and it can change. And you think like, oh, am I trying it out and I'm stretching the patient out, and then the resident or the learner tries it and it's a little bit different MAS score. And so, I want to make sure that they learn that. I think it's just important to have that basic knowledge, but then also, okay, well, let's talk about our Tardieu. Yes, that's going to be, we're getting the angles, the V1, the V3, and you know, and so that is something that it's probably a better test, definitely more time consuming. So I'm not doing it on every patient, but I think it's important to educate people about it. If therapists may have time to kind of do that, and I may specifically ask therapists to, can you look at these things, give me your assessment, and get some of those angles for and spasticity grades for our patients. So it is definitely, but in my opinion, better, more time consuming, not always doing it in my clinical practice. And again, I really want my assessments that I do to be patient focused and focused around their goals. So sometimes those goals are even, how does their brace fit? And that's not always a number on a scale.
Right. And that's a really good point. And I love the fact that you're engaging the clinicians. Not every clinic and facility has that luxury. And we'll dive into the communication between the different disciplines a little bit later. Great. Well, thanks for kind of setting the stage here with the definition and the assessment. Let's transition over to treatment.
Mhm.
For the audience, if you don't mind, just kind of, if you can just do an overview of from a clinical perspective, walk us through the full spectrum of the most common treatment options, obviously from meds to injectables, and then
Mhm.
finally surgical options. If you can do that, that'd be
All right.
great.
Yeah. Okay. So definitely treatment for spasticity needs to be multimodal. And when we look at it, I want it to be the physical application. So therapy, therapy, therapy. And that includes not just going to therapy, but doing your own therapy and exercise at home is going to be the mainstay of treatment. And everyone should be doing those things, including prolonged stretch and standing. Very important. You have the other non-pharmacological um, things that can be done that sometimes are not thought of, just electrical stimulation and casting and splinting and bracing and those treatments. Uh, then we have pharmacologic, and there's oral medications. I won't go into my pedestal about how I'm not a fan of oral medication in certain patient populations, because already, these are medications that have to go through your liver and your blood, and eventually very little gets into your CSF, where we want it to work around your spinal cord. So there can be a lot of secondary sedating effects to the oral medications, but they're there. And I will sometimes say, if a patient says, "Oh, I have a hard time sleeping because of my spasms," great. I have a medication that'll help your spasms and put you to sleep, because a lot of these medications do that. Um, and then there are the interventional medications that will be used for patients who have spasticity, and especially good at some of the focal spasticity, the botulinum neurotoxins, which we use. We do also have interventions that for doing neurolysis, whether that be with phenol or alcohol neurolysis, to look at nerves and nerve branches and use that for spasticity. Emerging treatments like cryoneurolysis, and so the cryoneurolysis is going to be another emerging treatment that's being used for spasticity. And then if we look further into, there are options for surgery. And so surgery is going to be, some patients may benefit who have more global spasticity from intrathecal baclofen treatments. And so intrathecal baclofen is another treatment for severe spasticity. I would say don't wait till the end to use that one. It doesn't have to be a last, resort type of treatment. There are surgeries that are done by neurosurgeons or other special surgeons that are doing selective now neurectomies on limbs. There are ones who are doing rhizotomies for patients who have spasticity. So a lot of things that are coming out. And then when it's contracted, then there's also surgery just for lengthening and tendon lengthening. And some surgeons are even trying to make, muscle exchanges and make it functional. So there's a whole bag of tricks that we have and that we try to coordinate for patients who have spasticity.
Well, definitely, I feel like there's a huge decision tree that you have to make. And in a second, I want to kind of, maybe you can just explain a little bit more an example of why you decided to not select, let's say, a toxin or an injectable, and you went right to a surgical recommendation. But before we do that, neurolysis.
Mhm.
Therapists don't learn a lot about phenol, alcohol, and definitely not cryo, which is more recent. Can you spend just a couple more minutes on those three options?
Okay.
And specifically, how would you decide which one to do for the patient based on those three specific ones?
Okay. So for neurolysis, and the way that I like to describe this when I teach my learners about it is, we're using a substance, whether that be phenol, which is also a carbolic acid, kind of an alcohol type alcohol, and or now very, very freezing cold with cryo. And we are putting it somewhere along so either a nerve branch, or a motor point, just kind of depending. And what these substances cause, for the most part, when we think about phenol or alcohol, it's, demyelinating the nerve. And we think like, okay, nerve myelation, we need myelin around the nerve to make the conductions go. And that's why our muscles move. And so we're basically demyelinating the nerve in some way using one of these substances. So we're basically creating a conduction block. So I said, we're giving a lower motor neuron injury to an upper motor neuron problem, but being, very focused on it. And so that is what we're doing when we're doing phenol, alcohol, and then now with cryoneurolysis, where, we're putting in something that's creating an ice ball that's going to, I don't know, something like minus 80 degrees Celsius, and is also doing the demyelination of the nerve. Kind of, if you think about demyelination, the Wallerian degeneration happens. And then with time, usually, we're not destroying completely the nerve. It's really just the myelin part of it. And so with time, that usually regenerates itself. And some of the spasticity may come back, and the procedure may be needed again in the future.
So how do you decide? Because you have so many options.
Right.
So let's just take that subgroup,
Yeah.
injectables.
Mhm.
Neurolysis. How would you decide between cryo, phenol, or alcohol? And
Rock,
and
paper,
and by the
scissors.
way, one last, sorry to interrupt. Did I get it wrong, or is it alcohol or maybe phenol that once you do the injection, it takes a long time if you even get that nerve to be activated again? Was that one of the warnings or indications?
No, not per se.
Okay.
Yeah. Um, And then always it depends on what the level you're doing. So if you're doing the full nerve, you may have, and you do a complete nerve block, then yes, you may really block it for a really long time. If you're doing specific nerve branches or motor points, then that may not be as full of a block if you're doing the complete nerve. And so that you can be a little bit more selective, and probably have a shorter duration of effect when you're doing a specific branch or just motor points with it.
Great. And then would you have a specific decision chart, or is it?
Yeah. So yes, great question. So specific decision charts, kind of multifactorial. So it is definitely an art to be able to do these types of interventions, and not a lot of physicians are trained in it. So it's like, okay, there's, certain physicians that can do these treatments. And so sometimes patients are referred to me because they've either, are kind of maxed out on the toxin that they can get just based on, their size, their weight, their insurance, those types of things. The other thing is sometimes we do it cost wise. The cost can be the differential between the cost of a toxin versus the cost of, phenol or alcohol is very different. Sometimes larger muscle groups may just be more amenable to getting phenol. Occasionally patients have have had, allergies or bad response to a toxin, can't get that again. So that's what we use. And the other thing is the onset is very quick for doing neurolysis. We have about immediate effect, and even like what we do at that time, they get about a 70% of the effect they're going to get right away. And we know, with toxins, there's sometimes a couple of week effect before it really starts kicking in and working where it's going to be at its peak. And so because of that, those are some of the things that go through my mind and decision tree for what I'm going to do for the patient. And so,
Well, what do you do then from an efficacy standpoint? If we're comparing apples to apples with spasticity as an upper motor neuron lesion for a chronic stroke survivor, which one's more effective? Is because I know Botox gets, that's like the leading actor for the Golden Globes, but is it actually more effective than Neurolysis?
they're different. It's hard to say, it's just depending on, again, who's using it, whose hands it's in, what the goal is that you're using for. I definitely would never, if I'm doing some kind of small muscles in the hand, I'm not going to neurolyse any of those type of thing, and that I always have to go with the toxin.
Interesting.
And
Okay, so for more gross motor
right. Yeah.
issues, you would then kind of lean towards Neurolysis.
Right.
Okay.
Yes. Right. Yeah. And then
Okay.
the other thing that is kind of related to that I even brought up is that the same process of neurolysis, we can do diagnostic blocks. So with lidocaine, because that reverses within a few hours. And that just gives us some information. And I love doing diagnostic blocks, sometimes even before I go through a treatment paradigm, because it is one of those questions where it comes out and, I'll discuss with a therapist, like, what is causing their stiff knee gait? Is it their plantar flexors? Is it one of their quad muscles? Is it just, something else? So we can kind of play with that a little bit with a diagnostic block. And if they become too weak, then okay, maybe we don't treat that. And maybe they need that fake spasticity for their strength. Or, oh yeah, it is part of their rectus that is causing their stiff knee gait. And so do we need to try to treat that now? And then do the neuromuscular reeducation that comes with therapy to help them break that pattern. Or if there's a question of, is this truly spasticity and how much is contracture, the lidocaine block is really, really great to tell us how much is contracture and how much is true spasticity.
Yeah, that you brought up a good point about the rehab part. I often explain spasticity to patients like it's a software problem running on perfectly good hardware. And of
Mm-hmm.
course, the software being, it's a brain problem, not a muscle problem. And so even if you just try to loosen the muscles, but if you don't rewire the brain through all those neuroplastic strategies, it's pointless. So, can you share an example of how you align, because patients before we transition to the guidance next,
Mm-hmm.
patients, not all of them are coming to you for neuroplasticity based interventions that are going to be combined with the toxin or the injectable. Some are coming just because of pain or, their nails are stuck in their palm.
Mm-hmm.
So aligning the right treatment, especially for therapy, might be a little bit different based on the case, right?
Right. Right. It is. And that's, again, knowing your patient, knowing what they want, knowing what their goals are. Some have very passive goals, some have more active goals. And then that also defines what we do, who we work with. Are we sending them for more therapy? And then the other thing is, some patients will say, the treatment didn't work. And like, what do you mean the treatment didn't work? I neurolysed you. I saw, you go from an MAS of 3 to 1. Like, it worked on paper. The same thing with, the botulinum toxin worked for you. And because I can see a drop in your scores, but they're like, well, I didn't walk. Well, guess what? Spasticity is one part of walking, and you understand that, but you have to have balance, and you have to have strength, and you have to have sensation and, proprioception and all these other things. And so what I give is just part of working with a big team.
Yeah. And there's positives to having spasticity. You can
Mhm.
potentially transfer where you wouldn't be able to, or you
Right.
can use that spastic site as a functional assist. So there's
Exactly.
those goals as well. All right. Well, that was great. Thank you for giving us the overview of the different treatment options. Now, I want to talk about the AAPM&R consensus guidance. This is this
Mhm.
little beauty right here that you sent. Thank you for sharing that.
You're welcome.
Um, So to set the stage, can you explain what this consensus guidance on spasticity assessment management is and why it was written?
Yeah. So spasticity is there's a good amount of physiatrists who, are trained in, well, everyone has to be trained in spasticity, but then also who practice spasticity. And we said this is something that is very impairing to our patient population. So there's not really good updated guidance statements for treatment of spasticity. So we came together as, some of the leaders in the organization. It did come from above. And then we found people who are leaders in spasticity to say, let's make a consensus guidance statement. Let's look at the data that's out there for the different treatments that we have for spasticity, for the assessments, for goal settings, just looking at it in a very holistic way, like we do as physiatrists. And then ultimately, we gave sort grades to some of the treatment options based on the evidence and also based on our level of expertise as well. And we published that and, came together and worked with this, kind of a lot of teamwork to be able to come up with our consensus. And so, like I said, it's very holistic. It talks about assessments, it talks about goal setting over the long term, changing those goals, and then it looks at treatments as well.
So there's a lot of different guidelines that we follow based on, for stroke. And some hospitals do a good job following them. Some countries do a good job following them. How do you get, your colleagues to follow the guidance? Obviously, it strongly recommends goal-driven spasticity management. So how do you help these teams move away, as an example, moving away from treating and assessing tone alone, quote unquote, toward more patient-centered functional goals? I mean, are you knocking on all the hospital doors saying, did you read the guidance? I know when I do, when I do in-services, I ask the therapist, which stroke guidelines are you following and why? And surprisingly, some don't even know which guidelines. They're not following any guidelines.
Right.
So that's kind of scary. So what are you seeing on your side?
Yeah. And I agree with you completely because a lot of it was like, did you know that, assessing and treating spasticity is level A evidence in the stroke guidelines? And, we need to look at that. And so you're right. Yes. And we are uh, looking at taking the guidelines and, presenting them to other societies and saying, like, can we make these guidelines in other societies? We're trying to educate as much as possible around them. We are working with pharmaceutical companies also to, when they educate their clientele around spasticity, then they cite the guidelines because the guidelines say, hey, spasticity needs to be treated. And these are the grades that, treatments get. And so these are things that need to be considered when you're doing goal-directed spasticity treatment. So, and then thank you, very fine individuals, get us on their podcast to get the word out.
Yeah, well, it's definitely educating the therapist as well, which is important. And I know there's probably CEUs that you all would be taking to spasticity updates. So there's some opportunity to reference that as well. One mistake I see in treating spasticity is this like one and done problem. But spasticity is dynamic and things change over time. How often should patients be reassessed when they come to see you? And what should trigger that, change in treatment plan over time?
Right. So as I'm seeing patients, if there are some of my patients that, they've been my patients for 10 plus, 12 plus years, and they just see me and they're seeing me every 3 months. And a lot of times they're getting some, intervention maybe at that mark. But I'm definitely assessing them. And even if there's coming for an intervention, I'm saying, how did we do? Are things changed? What can we address again? Are you in therapy? Are you doing exercise? What are you doing? Did you get too weak? Did you get, was it perfect? Are we adjusting anything? What are you saying? So always getting feedback from the patient. I love getting feedback from the therapist too. That's always like super helpful to me. So, if someone is well controlled, then I may only see them a couple of times a year. If they're people who are still needing a lot of interventions it's a chronic disease state. Now, once you have a more, severe neurologic injury, then we continue to see them with more frequency.
How long should one receive? Let's use Botox. You mentioned toxins. How long is there like a cap when you say, okay, we've done enough? Or
No,
or is it
it's
decades?
goal directed. Yeah. So if patients continue to need it, if it helps to meet their goals, if it improves their quality of life, it allows them to, open their hand and, do what they need to do, then we can continue to use it safely. And it's been shown to, over this time to be used
Do you
for.
think some of the physicians might say, okay, we've been doing this for 5 years, let's try a different approach? Or is it always every 3 months, another toxin?
It just depends on the physician. I'd probably say there's some that are like, here you go. And then some may, okay, let's try a different approach, or let's switch to another toxin, or let's do neurolysis now. Or, a lot of times even patients come with oh, I saw that video you put on cryo and now I want to learn about cryo. And so,
Yeah, well, that's definitely another upcoming area. If there's from the outside looking in, some of the advantages that I'm learning about cryo is the immediate effect, not needing the quarterly injection because it may last 10, 12 months. And obviously, it's not a toxin going into your body. Of course, some of the downsides I think were a little bit more involved, maybe some soreness, pain that you may not otherwise. Is
yeah.
that pretty much the summary of the ups and downs
Yeah,
of potentially
definitely.
choosing that?
Well, first, right now it's being studied in some case studies and case reports have come out. It's being used. It's been used for pain. That's what the indication is right now for pain. So if
Yeah.
there's pain related to the spasticity, then we could use it in someone who has spasticity. But just like only spasticity is not really the indicate. That's the study that's going on now where they're trying to get that indication just specifically for spasticity. It is more time intensive for sure, and it is because it's a bigger needle and a longer procedure, definitely more painful to the patient.
Okay.
Yeah.
Well, good. Thanks for kind of summarizing that. I want to switch to an article on disparities, access, and health equity. You
Mhm.
wrote an article, or co-authored an article in 2024 in March, American Journal of Physical Medicine and Rehab, Disparities in Access to Spasticity Chemodenervation Specialists in the United States. It was a great read. Congratulations on that one. Your research highlights major disparities in this access to spasticity care, particularly in these non-urban and Hispanic populations. So what surprised you the most about these gaps?
Yeah. So I'll give just a little bit more background to it. So really, we were looking at Medicare population of patients. Got big data sets from Medicare, and we said, okay, how many patients were getting spasticity treatments, and what we used to consider who was a spasticity chemodenervation specialist was looking at the CPT code. So those are the billing codes for, using one of the toxins in a procedure. And we said, okay, a specialist is a physician who's treated patients at least with 10 of these codes per year, which is not, that's like one half day of clinic for me, but
Right.
we're being very broad with the definition. And what
Yeah.
to me was one of the most shocking things, and this is for Medicare patients, was in the whole United States, there was only 566 clinicians that were considered spasticity chemodenervation specialists, which in the big United States, where we have someone having a stroke every 8 seconds, this number is really,
Problem.
really small, is a problem. So that's where we said, okay, well, now let's look at, urban areas versus rural areas. Let's look at, maybe patients who had Medicaid and Medicare. Let's look at patients who, in areas where there's more Hispanic patients or Black patients. And, what we came out was definitely, if you're in an urban area, you had more access to these specialists, especially if you're like in one part of the Midwest and a certain part of the Northeast. These urban areas had very good access to, or fair access, if you think 566 people in the country, versus if you're in a rural area, then your access to getting specialists was, terrible. And then we looked at also, like I said, all these other differentiating factors. And the one that ended up also being statistically significant was areas of higher Hispanic population. So for Medicare, that would be considered places where there's 25% more of the population is Hispanic. And 10 out of 12 of those areas are Texas and California. And I'm in Texas, that, I know that there's not enough access here, whether you're urban or not.
So how do we fix this problem? What is a solution to address this non-urban and Hispanic access issue?
Yeah, I think it is, part of education, making it favorable for people to want to for physicians to want to treat patients with spasticity, as far as, and having practices. It's continuing to train our future residents. It's maybe making sure in our practices that we have enough people who have interest in it, who maybe we train our APP workforce to help assess these patients and for us, and, so we can get them in and treat them. But yeah,
Well,
definitely. And not just physiatrists, neurologists are doing this as well, of course.
well, based on your work, I mean, how realistic is I mean, obviously you got to physically be there to give them the treatment, but telemedicine or alternative care models that
Yeah.
we're not thinking about as a way to expand access.
Right.
Mobile, I guess. Do you have
Right.
mobile Botox vans?
Right?
You know?
That could work. In Texas, a big state. Yeah. I'd
True.
have to be driving around a lot. But I
Get
think
your gas
telemedicine is
reimbursed.
great for assessment. So I said, sometimes it's really hard for these patients to mobilize. I think that, getting them from if they, I have patients that travel 5 hours to see me because of how big the state is and how many rural communities are around us. And uh, so it is nice if I could do a telemed appointment for the assessment or for the, 4 weeks after the injections. Oh, what worked? How did it go? And then they don't have to their family doesn't have to make the big drive in, 10 hours round trip, stay in a hotel, whatever it is that they may have to do to take care of their family. So I think, it's important that we continue to extend telemedicine because it's been very beneficial for my patients. And um, yeah, we haven't used AI to like do an injection through the telemedicine port yet, but
That'd be pretty cool, wouldn't it?
it would be pretty cool. Yes.
Yeah, I mean, that problem is a problem for us as well. I mean, when these patients get discharged from inpatient and they go home, they're lost in the system, most of them.
Hmm.
And if they do go to a therapy clinic, like you said, it's not a specialist. They're going
Yeah.
to Bill's physical therapy, hip and knee,
Yeah.
who see a stroke every 3 months.
Yes.
And
Right.
that's so they don't know what to do. They're doing things that are 40 years old.
Right.
And so the patients, at that point is going to have a serious issue because of where they live, and their that community. So it is a major problem. And tele-rehab is definitely not taken off for neurorehab at least. I mean, it's good for maybe cognitive and pediatrics and mental health. But when it comes to stroke or neurorehab and spasticity management, it's really tough to do tele-rehab because you got to get your hands there and really help them. So it is an issue.
For sure.
So economically, great transition. A lot of people, I know some patients I speak to, they always hear the treatments like injections or, God forbid, a pump. If you have to get that, some of their surgical things, they automatically, gee, that sounds expensive. But you did another study on cost efficiency analysis for spasticity management based on Botox prescribing habits in 2021. That was an ACRM article in the archives. And that although it sounds expensive, and I want to hear about that study because your research suggests that it suggests the opposite when we're looking at the bigger picture, which is hospitalization and ER visits. So can you explain why treating spasticity appropriately and of course early can actually reduce the overall health costs?
Right. So that was something that we were like, yeah, what happens to a patient that, has stroke and someone who gets a botulinum toxin injection and someone who doesn't, and actually looking at their costs, going forward. And you think if someone's spasticity is well treated, that it decreased the cost of care. They may have had less falls that need to go to the emergency room. They may have less complications. May have less need for, getting surgery to release their tendons that are tight. They maybe don't develop the wounds that sometimes can develop in people who have really terrible spasticity. So in looking at that study, it was like, wow, actually, you think like, oh, botulinum toxins, expensive thing. But in the end, it saves money to the system. And I think sometimes we need to take these studies and we need to show them to our insurers and to Medicare. There's like, okay, you want to deny this care or not give this care, but actually it will save you money in the end because these patients are not going to the emergency rooms, not being admitted, not needing wound care or surgeries or any, these other things that can increase their cost of care. So it was a nice look at that because we do know there's other studies that show someone with spasticity versus someone who doesn't have spasticity. Their costs are 4 times more than someone
A
who
lot.
does not have spasticity. It's a lot.
Right. It's a lot. And that's why we have to address it early. Just like stroke. I mean, if you can take advantage of that cerebral sweet spot in the first 30, 60, 90 days and just flood the brain with neuroplastic principles, you could eventually, potentially, get them, evidence shows, at a higher level functioning status, which will then ultimately cost less to the system.
Exactly. Yeah. Do it early. But
Yeah,
also, if you don't get it early, don't give up. I still want to see you.
yeah.
Yeah.
Well, despite the similar clinical efficacy across, this is something that I was just, I didn't know too much about as a therapist. But, when you look at the different types of toxins available, And I, spend a second if you don't mind. There's is it ONA and ABO and UNI? I don't know how the different ones, but one of the articles talks about how the prescribing habits of the physician choosing Botox, if you will, the primary one versus let's say Dysport or Xeomin is a lot more expensive. And that's just a natural reflex, sign me up for Botox, which is more expensive when those other ones have comparable results. So am I offline saying that, or is that true when it comes to those three different examples?
Yeah, it is. When we did the study, it's like, what are the prescribing habits of physicians? And yes, most will use the onabotulinum toxin, which is Botox. I think, it's been around in the market the longest. A lot of people were trained on it. They have a lot of familiarity with it. It became the word, the verb for botulinum toxin. And so just like the Kleenex is the tissue. And so it just happens to be used the most. And when the competitors, which had been some of the competitors were in other countries and markets, for a long period of time as well, but they came to the U.S. market, and of course wanted to be competitive, CMN, Dysport, and so their costs, they made their costs a little bit better. And we looked at that from if you're a Medicare patient and you have to pay 20% your cost of medications and treatment, it's going to be 20% is going to be less if the toxin costs 30 to 40% less, of course. So
why
you're
is that
thinking
not
about
a bigger issue?
pharmacoeconomic. Yeah, go ahead.
Why is that not a bigger issue amongst your colleagues regarding, when you think about accessibility, affordability for the end user? If it's just a natural prescribing habit problem, if I knew there was three different types of eStim devices to help my patient, one was 300, one was 200, and one was 100, and they all were comparable, why would I be prescribing the $300 eStim unit?
It's a really great question. I don't know. Yeah. Yeah, I don't know if it's their comfort. I don't know if they, I don't know how to inject that one, or I haven't used it before, or, or they're not looking at the costs in the back. Sometimes physicians are just employed and they're just treating the patient and they don't see what is the cost to the patient or what is the cost to the system. So I think that's also a big issue.
Well, I'm glad these articles are out. So hopefully more conversations can take place. That's obviously a big issue.
Mm-hmm.
All right. Well, let's switch gears to, I did have a question regarding caregiver experience. From your perspective, what do caregivers most often tell you about the day-to-day challenges of managing spasticity for their loved ones at home? When they come see you, what are they typically, discussing with you as far as the challenges that they incur?
Yeah. So caregivers, hats off to you. Really, thank you for the job that you do in taking care of your loved one. And a lot of times you'll hear either challenges that the patients have with either trying to do activity, trying to do exercise, like, oh, well, we try to do some of their exercises, but it hurts, or they can't stand on their foot right. Or, if we try to stretch them, they have pain in their arm. It's like, they're letting you do more than, my clinical assessment is more than they let them do with them at home. And then you hear a lot about the passive, quality of life and caregiving goals. So it becomes really hard to try to clean them because of their spasticity that they may have in their upper limb, or, their fingers are digging in and they can't get clean their hand, and their hand starts smelling, and, or transfers become very, very difficult because of the tone that they have. So these are the things that we're hearing from caregivers, is these passive quality of life, caretaking, ease of caregiving goals, and also the pain that the patient may have related to their spasticity.
Yeah, those are all good, and that makes sense. What is the soonest you'll see a family post stroke from the evidence standpoint? How early will you see them for let's say, a toxin as an example?
It kind of depends. If they're, if they've been through inpatient rehab, if they have a, place where, okay, they set them up for the outpatient appointment, maybe they'll come in another, 6 weeks or however long it takes to get into clinic, then that's great. We can do the assessment. Sometimes spasticity hasn't developed fully while they're an inpatient, and then they go home and things, start developing. And so then we can see them in clinic and get them treated as soon as possible. So that's nice when it happens within, a couple of months from their stroke. But that timeline doesn't always happen. And so, but that's kind of the best case when it's early and right when it's developing. So you can kind of treat it and continue them on their therapy journey.
Yeah. And of course, the therapist is, once they're discharging them from inpatient, the tone's probably kicking in maybe 4 6 weeks for some earlier. And obviously that communication's going to be pretty key. And that's what I wanted to kind of just touch on real quick. Tell me about your communication with your OTs and PTs. I mean, how often and what are those discussions like? Because I can tell you from my perspective, feel free to disagree. I feel like, and you kind of proven my point when you said there's only 500, 600 specialists, these clinics. I feel like it's an 80-20 situation where 80% of the therapists working with stroke survivors do not have an intimate relationship with a spasticity physician specialist like yourself. So that decision team, which includes the patient, caregiver, clinician, doctor, doesn't exist for 80%. So what happens in my perspective is patient goes to, as we said earlier, Bill's physical therapy and hip and knee clinic, which she's a stroke patient ever so often, says, gee, your hand's tight. You should go to your doctor and ask for Botox. And that's the end of the communication versus the other spectrum, which I think yours is. So walk me through real quick. What is your communication with your clinical staff? How often does that occur? And I'm assuming you're the part of the 20%. So
Yeah, I'm probably the other 20%. I mean, I have on one end of the perspective, I also do some pediatric rehab and take care of, children with cerebral palsy mostly or spinal cord injury and such who have spasticity. And we actually have a multidisciplinary clinic at one end of the spectrum, which is like myself, pediatric orthopedics, a pediatric physical therapist, and an orthotics specialist who come and see patients in one clinic. And we are seeing them together just about their spasticity at that moment. And we're deciding like, oh, this is something, well, we'll try this injection and then we'll do, and then the PT's setting up the serial casting for right after the injection. And so then the orthopedic surgeon saying like, okay, we'll see how that comes out. And if they're still contracted, we'll do the surgery. And the orthotist is like making the appointment to do, make the brace right when they're done with that. So there's that kind of communication. And we're all in the same electronic medical records, sending each other messages and, oh, reorder the orthotic and they're done with their casting and, all these kinds of things. So that's like best case scenario end of the spectrum to, what you describe. But even for patients who don't end up in a multidisciplinary clinic, I always say I love hearing from your therapist because I will spend, 30 minutes with a patient every, couple months. And then the therapist is spending hours with them compared to me because they're seeing them several times a week over weeks, over this long longitudinal relationship. They have their hands on them so much more than I do. They're seeing them, transfer, walk, do new things, definitely more than I am. So in some cases, it's either they can send me messages if they can, if they're in our system, or I'm even a fan of like, have them write you a note and bring the note with you when I see you so I can look and the therapist say, oh, this improved this many degrees. But I really think, I mean, some therapists are as good as sending me a list of like which muscles they think. And so together we can come up with a plan together for the patient. So I am not one of those doctors. I'm so happy to like get insight from the therapist. I'm not any better than you. The neuromuscular, especially if they're a specialist, they know the neuromuscular, system just as well as I do. And so I want to work together for the best outcome for the patient. And, no one has more hands-on with my patients than the therapists.
well, yeah, you're absolutely right. We're like extended family for many patients, and the trust aspect is significant. So when we say to the patient, you really need to go see, Monica, and you need to get these toxins or have her decide which one's the best, and these are the muscles you need to focus on. They're getting their keys and going down the street, right? So
Mhm.
the patients really trust most therapists because they spend so much time with them. It's like extended family. Going back to that article on inequities access, what do we do? With all those facilities, the 80% that don't have that beautiful dream team.
I
Um, is there any thought regarding what AAPM&R is talking about with giving more access? Is it a finder? Spasticity clinic finder that's easy for everyone to find. I know you still have to drive 2 hours for some of these
Right.
folks,
Mhm.
but has there been any progress at all with trying to shave the 80-20 to 60-40?
Yeah. So we actually are about to, through the AAPM&R, our national society, come out with a big educational module around spasticity that's interactive and can give CUEs and such. And so that's something that's going to be great for, clinicians and therapists. And then they do have also a spasticity physician finder, like find a physiatrist in your area who treats spasticity. So we have that through our webpage as well. So we're really, increasing the educational opportunities as well as, have a list of physician finders who are willing to, treat these patients. Yeah.
Right. Well, the last 2 points, one is more for therapists, is obviously this conversation's been fantastic on many levels. I think from a therapy standpoint, we have to remember that if it's great to know the differences in the treatment options when it comes to the medicine, the toxins, the injectables, and the surgery. More importantly, for many of the reasons, when it comes to neuroplasticity, not so much pain and hygiene and function, but let's just call it neuroplasticity. You really have to understand your stroke guidelines, and you have to understand, even your AAPM&R article did a fantastic job talking about task training, CIMT, E-STIM, all the things that are proven to be evidence-based. Great. Those are more of the top tier treatment strategies. Of course, when you get to stretching and other ones, those are kind of temporary. So you got to be careful that you're not spending 45 minutes just stretching. Again, it's a brain problem, not a peripheral problem. So there's room for everything at the table. You just got to prioritize. The ratio needs to be correct. So if you're a therapist listening, the key message here is, as you're working with your physiatrist, make sure you're providing evidence-based care. And if you're not sure, obviously there's 9 different guidelines, maybe 10 at this point, international and of course in the US, and make sure you're providing those, such as FES, task training, CIMT, strength training. There's not going to be an increase in spasticity when you do strengthening. It's an old myth. There's a lot of old myths. And so that's on you as a clinician to be accountable for that, so you can actually treat those patients appropriately. Physiatrists are doing their job, therapists need to do their job. My last question for you, Monica, and thank you so much again for your time. You future call to action. This might have been what you just mentioned about what you guys are working on with access. But what's next on the horizon in spasticity management that gets you excited the most when you get out of bed and saying, yes, there's something coming in the next 3, 4, 5 years that's getting you really excited? Are we there yet for you, or is it more just communication?
Both things. I think, like, when it comes to access, there's so many patients who are not even getting therapy after strokes. Like, the numbers are shocking, so getting access to seeing a therapist, and yes, a specialized therapist, but any kind of therapy would be great. And then the other thing that really excites me is they're coming out with the novel toxins now, the long acting recombinant toxins. So imagine if someone only needs an injection every 6 months instead of every 3 months. That allows more patients into my clinic.
Sure.
That allows them to travel, 2 less times a year, have 2 less copays a year. And so those are definitely coming out in, phase 2 trials and such.
Wow,
So,
that's great. Is that
yeah.
the 3 major players are doing that, or just one of them? Or
One of them, they're all kind of looking at it. One is a little bit more ahead than the others. Yeah.
okay, that's fantastic news, because that would reduce it in half, cut the cost down too, which
Yeah.
would be exceptional.
Right.
And I think that's important when you're thinking about, your future ideas. And, we've talked about treatments, access, costs. We talked about patients and caregivers. I just want to zoom out from my last point
So I
for a
do have
moment.
one more thing that excites
Oh,
me
sure.
that I think is very pertinent is some of the neuromodulation things that are happening. Like, if you think about the vagal nerve stimulation and for chronic stroke patients, because I actually see with improvement, some of them are actually, like, their spasticity is decreasing. Well, first, if their spasticity is too bad, you have to treat their spasticity. And then they're seeing improvements, and some are needing less and less spasticity management as they gain more motor control.
Yes, definitely a big fan of paired VNS, or vagus nerve
Yeah.
stim, the implant. And obviously, in order to qualify, you're part of that pre-qualification for some.
Mhm.
Others, it's while they've qualified and doing the treatment. But by definitely reducing the spasticity, they can actually engage that hand more functionally, which then allows them to do task training, which allows them to improve.
Right.
And of course, boosting that with a paired VNS is a fantastic thing. So, all right, finally, if you could change one thing in our healthcare system tomorrow, or even
Mhm.
today, it's only, 11 o'clock your time? We could
Right.
change one thing in our healthcare system literally now to improve spasticity care. I know you've talked about a lot of stuff. What would it be? I mean, is one superior?
What would I
Snap your
change?
fingers and you've changed it.
And I changed it. The other thing I didn't even touch upon also is I really feel like there is, a whole proportion of patients who are in nursing homes and nurses, with terrible spasticity, who are not being managed. And some of it is like, well, care can't be given in that facility. Like, you can't do a toxin in a nursing home, and they have to either come, or they just let them stay there and, live in pain with all their spasticity and developing contractures. So is there a way that let's switch that. Let's be able to like come to them and treat them in that facility. I think that would be a big way to get a patient population, maybe more with the, their passive needs and with their pain and positioning. But I think that would be like an easy fix. But also, yeah, so much.
Access, right?
Access. Yes.
I love it. And early and often, right? So I think early access is the key.
Right.
Well, thank you so much. This has been fascinating. I know the caregivers and patients are going to love this one. The therapists will as well. And any of the physiatrists that are listening, new grads especially, this will be fantastic. So I really appreciate what you're doing. You're doing a phenomenal job. And your patients and family members are lucky to have you. And your therapist, geez. So this is fantastic. So please do keep in touch. And thank you for your time today.
Yeah, thanks for having me.
Okay. Have a good one.
Thank you for tuning in to the No Plateau Podcast. Please make sure to like and subscribe to stay up to date on more stroke and brain injury recovery stories. The No Plateau Podcast is intended to give you an insight into stroke and brain injury survivors' journeys. Any opinions given on this podcast are strictly the individual's, and we do not suggest that you necessarily hold the same viewpoints as anyone on this podcast. This podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with any questions you may have regarding a medical condition. Reliance on any information provided by the No Plateau Podcast is solely at your own risk.